All right, so this was the topic that was assigned to me, or at least the title of the talk, and so I'll just try to make it up and talk a little bit about this, because I do think that we are at a stage where we're creating this paradigm shift. Here's my disclosures. If you look at this, the term paradigm shift came from Thomas Kuhn, who's a physicist and a scientific historian. And he remarks in this book, which actually, if you haven't read this book, you really should look at it, an important change that happens when the usual way of thinking about or doing something is replaced by a new and different way. And I think that's why we're all here, is to figure out how to do things in a new way and in a different way. And so what's frustrating is that we have papers and articles that are coming out that are saying that, you're not any good. Why are you even doing bronchoscopy in the first place? And there's some talking heads who get up at the same conferences at CHEST every year and say that you're horrible at bronchoscopy. And so I want to discourage that kind of thought process and really hopefully show you that we're really moving forward. And this is a quote from this article. And to be fair, there have been, up until relatively recently, some improvements in technology, and we haven't seen the diagnostic yield kind of keep up with that. But I think that we're definitely on the verge of this paradigm shift. So how do we bridge that gap between where we've been to really where we want to be, to where CT-guided needle biopsy is and things like that? And it's not all about navigation technology or imaging. There are other things and other technologies. So the title of this category is Rise of the Machine. So there are other machines that can help out. This is an automated slide prep machine that we've been working with. And so if you don't have cytotechnologists that are there, or they're not trained, then this can take that workload off of them, and it really creates great stains. We're looking at dynamic cell imaging, and this is going to be ripe for inclusion of AI as well. And this basically is a heat map, and so you can be your own pathologist, and we're using this in combination and studying this now. And this looks at the entire sample, and it's able to slice without touching the sample. So this is all imaging. The sample is untouched, completely preserved, and still goes to the pathologist. But during the procedure, you can look at this, and it's like a PET scan for tissue. It shows you a heat map of metabolic activity. And so what we can see is that these large yellow cells are metabolically active, and those are cancer cells. And so it helps determine adequacy. We're not trying to replace the pathologist, but we're trying to help them and help the proceduralist know when they have the tissue that they need. Obviously, we're all talking about robots, and that's kind of the title that was assigned to this, and we know about these robotic platforms that are out there. And so in some ways, there's very big robotic wars. They want to pit me and Kyle against each other because you're Ion and I'm Monarch. But we're all trying to do the same thing, which is get better and better. There's now a new player that's coming in the Galaxy platform that will probably be FDA approved here very soon. And so this two-person robot war has really turned into a three-person robot war in the United States. And it's a good problem to have, because the competition is driving innovation. And so here's a comparison of those platforms, and I won't go into great detail. You can take a picture of this, but basically some of these are electromagnetic navigation, some of these are shape sensing. You see the different catheter sizes that are there. You have reusable, you have disposable on the side of Galaxy. And Galaxy has a built-in tomosynthesis algorithm. Ion has incorporated mobile cone beam CT scan, full integration that talks with the software. And so these are all version 1 of these robots. And so I think that they're just going to continue to get better and better. The pace of innovation with some of these companies that we've seen thus far is very exciting. Some unique features that we see that we haven't seen in a navigation platform before, like the automated anatomy border. That purple line that's around there is showing you where the pleura is. And that's unique, and we haven't seen that before. So how does that come into play? Well, we have new needles that we didn't have before. These needles lock onto the robot, and you set the depth of the needle, just like an EBIS needle. Well, we don't really need to set a depth when we're doing EBIS, because we can see how far our needle is going in. But out in the periphery, you can't. But now you have shape sensing data, so you can say, okay, I know that the front edge of this tumor is 8 millimeters away, the back edge of the tumor is 19 millimeters away, and if I go to 28 millimeters, I'm going to hit the pleura. You have to understand that this is also virtual. So if you're getting CT to body divergence, then you may not want to trust these numbers, but they're a good guide if everything else is on target. And so when you have needles that are now 3 centimeters long, which is also new, the PeriView Flex that most of us have been using 2 centimeters long, so we're pushing the boundaries with new tools as well. I wanted to just show this video to highlight what these robotic scopes can do. This is a patient with obviously very severe bullous emphysema and a spiculated lesion that's sitting on the pleura. So interventional radiology was not interested in seeing this patient, nor surgery. So this is not sped up. This is how fast it takes to navigate with this platform. It's very responsive and will kind of drive as quickly as you want it to. And it's also 3.5 millimeter outer diameter catheter, and we're using that so as not to create trauma going into some very small openings. And what you'll see there is that we're driving inside of this emphysematous bulla. And we're seeing things that we've really never seen before, and it's kind of mind-blowing. So these are just dead vascular tendrils that are there. There's no discernible lung tissue. So there's nothing to hold a catheter up. There's nothing even to hold an ultra-thin scope up to a certain degree. But the robot, with shape sensing in particular, keeps its shape, even though there's nothing supporting it or holding it up. That little white plaque on the back wall is the lesion, and you can see the numbers on the right side of the screen getting smaller and smaller and smaller as we get closer and closer to this lesion. And so at the last second here, we'll pivot over to the right, and we'll go to the center of the lesion. And you can see that it's matching up perfectly with what you see visually as well. We'll do a radial probe. We put our radial probe in. We get a little bit of an eccentric signal. You can see the radial probe bending to the superior part of the lesion, but we know with a needle, it will go right in the lesion. And so that was our preferred choice. You get a little pushback, but again, there's nothing holding that up. But with the shape sensing, it resumes its shape each time. And so we're able to do these things. I'm not a big fan of cadaver studies, but I think one of the questions that we have to ask is, well, is this shape sensing thing any better than electromagnetic navigation? And that's kind of what this study sought. And what we saw was when you drive out to the lesion and you trust the navigation system and you blindly put the needle out and then do a cone beam spin to see where you're at, 80% of the time ION was on target with the shape sensing compared to 45%. Now this was before Illumicite and things like that. So had they have done a fair assessment, it would have been a different story. So this is basically doing that same thing in living, breathing humans, and what they found was that shape sensing by itself without any adjuvant imaging is on target 85% of the time. So that's a step up, but there's a lot that happens after that. Getting the tool in the lesion is part of it, but then it's up to your skill and what tools you use and how persistent you are and how good your pathology is. So there's a lot of variability there. So I'm pushing for us to start using tool and lesion confirmation even as a superior measure over diagnostic yield, because there's so many variables in diagnostic yield. This paper was published in Chest. Yield is 82%, 100% for lesions over 3 centimeters, and a very low pneumothorax rate, which may be related to the special needle or the anatomy border and things like that. But we're trending the right direction. So again, think in the context of that new Chest meta-analysis that says that we're not getting any better. And we're trying to do prospective multi-center trials. This is the one with ION. There's also a much larger study with Monarch called the Target trial that's coming out. And this is split between 11 different users at 6 different sites. And some early data from the CHEST meeting really turns some things on their head. We've always associated a BRONCHUS sign with a higher diagnostic yield. And so what we're seeing now is that the BRONCHUS sign isn't mattering quite as much. The sensitivity for malignancy is not changing, and there's no cone beam or advanced imaging in any of this. And so that's how we want to be able to make this generalizable. This is compared to CT-guided needle biopsy. This is out of the Mayo Clinic, and they compared it's a multi-center retrospective review, no cone beam or anything like that, and they used their robot with CT-guided needle biopsy. What you can see is a big difference in pneumothoraces, obviously, and importantly, about 40% of patients had to have additional staging if they had a TTNA. and had they all had a robotic procedure, they would have had EBUS staging during the same procedure, and they would not have had to go for yet another procedure. And what about this? Again, no advanced imaging in this, no cone beam, but they got a diagnostic yield of 90%. That's using new tools. This is using the 1.1 mini cryoprobe. You heard Felix talk about this earlier in the mediastinum, but we're also using this through the robots, through a thin scope, through whatever you want. So it's not all about new machines and new toys. Sometimes it's about new tools. And the interesting thing is that in 18% of the cases in this study, the 1.1 mini cryoprobe was the only tool out of all that were used to get a diagnosis. This is just our cohort when we use cone beam CT scan with the robot, high diagnostic yield at a very small average lesion size, and particularly even for lesions 10 millimeters or less. So when we were in the last panel, and they said you get an 8 millimeter nodule on a lung cancer screening, we're going to go after that, and we're going to biopsy that, and chances are we're going to get a diagnosis. And this is just another study in full publication, not just manuscript, about the combination of robotic technology with fixed cone beam CT scan imaging. So again, we're starting to bridge that gap and see those numbers go from 70% yield to, again, 91% diagnostic yield with a 1% pneumothorax, only 0.5% requiring a chest tube. Is this generalizable? So one of the companies has an app on their phone, and so when you're done with the procedure, when you get the final pathology results, you can input it in, and it marries that with the data from your robot, and so it keeps that. This is not peer-reviewed data. You have to trust people. So again, this isn't for publication, but it allows the company to keep an eye on things and say, how well is the whole field doing? And if there's a trouble site that's not doing well, then they can intervene and say, hey, let's go talk to this site because their numbers really aren't great. So that's encouraging, but again, we really need multi-center prospective trials to do this. What it's done for us is it's made our cases overall much shorter. And we're much more efficient. This is our typical daily schedule. We do 6 to 8 robotic cases in a day, and that's also usually combined with EBUS staging as well. And so we can be very efficient with this technology, which helps us out overall. The mobile cone beam integration that I mentioned before, this is a 30-second scan, and you saw this a little bit in one of Felix's talks earlier. Not everybody can afford a fixed cone beam system, so this is a mobile system that takes 30 seconds to do a spin, and then that information is immediately at your fingertips, and you can scroll through and see where the mass is, and where your tool is, and where your catheter is, and then you tell the system where the catheter tip is and where the lesion is, and it will update the position for you, and that's full integration. So the hatched out one on the bottom is where you thought you were going, and then you made an adjustment to where the lesion really is. And so that's where things are going with the real-time imaging incorporated into that. For the sake of time, I'll go through this a little quick. This is an abstract from Galaxy, which is exciting. Kyle mentioned this a little bit before. 100% tool and lesion. We have 2 of the authors here with Kyle and Chris, or 3 of them, and Bobby. Everybody but Otis is here. So again, encouraging in an animal model that when you're using tomosynthesis or real-time imaging, it always tells you where you're at, and then the rest is really up to you. And these are some fantastic images when you compare diagnostic CT to tool and lesion tomosynthesis in the middle compared to cone beam CT scan. So you can see it's very accurate compared to that. The MONARCH clinical evidence, this is Kyle's case, 77% diagnostic yield and low pneumothorax rate. But look what happens when you incorporate real-time imaging. So when you add body vision to MONARCH, then you're getting a much higher diagnostic yield. If you use the very strict definition of acquire, 84%, accuracy is 91%, comparing to like the benefit definition or even the navigate definition. So real-time imaging really brings up any technology. And so when you look at these as a whole, these are all the studies with robotic and tomosynthesis. I really need to add body vision studies on here. Well, this is body vision with MONARCH there, that orange dot at the top. And so what we're seeing is this is where the navigate data was. This is where they're telling us, hey, you're not getting any better. And these are all studies that were probably not likely included in that meta-analysis. And so what we're seeing is that we are above that line. Now, what happens when we take out all advanced imaging? So this is without cone beam, without tomosynthesis. We still see that a lot of these are above where we were at with the Navigate data. So that's encouraging that we're moving in the right direction. So in the end, robotics is definitely a part of this paradigm shift, but new tools will be a part of this. But in my opinion, the key player in this paradigm shift is real-time imaging, whether it's Illumisight or Body Vision or Galaxy or Ion with cone beam integration or mobile cone beam. I didn't mention, BrainLab Aero. We've got people using that. The Medtronic O-arm is being used for real-time imaging with these cases, and I think that's really what's creating the paradigm shift. So with that, I'll stop. Thank you.